We're still talking about the anemias, basic intro to the anemias. We talked about thalassemias and globin synthesis and microcytic anemia and the transferrin, the TIBC um, markers, TIBC being the test to measure the blood's capacity to bind to iron with transferrin. And moving back, we talked about modifiers and basic things about anemia. Um, Blood loss, etc. Anyway, let's move on. Okay, let's move on to the normocytic anemias. Well, we've discussed it many times, but it's very important to understand sickle cell disease. So, in the homozygous state, big S, one nucleotide change in the codon causes what? What is replacing what? Valine is replacing glutamic acid at the sixth position of the beta globulin chain. Remember that. Heterozygous, big A, big S, sickle cell trait. What are the complications? Many. Sickled cells block small blood vessels and cause a painful, very painful crisis. So give us some more detail here. What do we know about sickle cell anemia? So we know that the DNA is mutated and there's a coding problem here. They block capillaries, of course. What else can happen? So just to throw out a quick question here, how many African Americans are heterozygous for sickle cell disease? The answer is 8%. So remember that in the disease state, remember this is a recessive trait, so you do need to have both. So in the homozygous state, the reduced hemoglobin sickles, and this is where the problem comes, of course. So let's hear some more detail here. So we've said that it causes a lot of pain when they become occluded, when they occlude capillaries. So give us some more clinical features of the HGB-S disease. So what are some more things you would see? Severe anemia, jaundice, and we talked about the pain crisis. So this vaso-occlusive disease is everywhere, but clinically it is significant in bone and especially the spleen. And we'd see autosplenectomy. What is autosplenectomy? That's when you see the spleen actually disappear. We've talked about the mechanism of that before, but remember that also patients become susceptible to certain infections. What infections would they become susceptible to? Can you name them? Pneumococcus, Haemophilus influenza, Salmonella osteomyelitis. So now on to non-hemolytic anemias. We're talking about what type of production? Decreased production. So how about those megaloblastic anemias? We talked about the features of megaloblastic anemias and the problems with DNA production. What more can you tell me about the megaloblastic anemias? How about concerning pernicious anemia? What is pernicious anemia? What type of deficiency is involved here? This involves B12 and folate deficiency. So we're talking about iron deficiency, anemia of a chronic disease, aplastic anemia, pure red cell aplasia, and other forms of marrow failure. But think first of all, probably for testing purposes here, about B12 deficiency and folate deficiency. Very basic. And yes, we have looked in detail at the megaloblastic anemias and remembered that it's impaired DNA synthesis. What's happening is, just to summarize, is that we're not seeing mitosis. What's happening is we're just seeing that the cells get huge and block everything uh, rather than going through mitosis. So think of the anemias concerning B12 and folate deficiency and this causing the problems. But they are very hyperplastic, and you would see, very hyperplastic and hypercellular marrow. And just for a reference, mean cell, uh, the mean cellular volume here. What would be the mean cell volume here for differentiating megaloblasts from macrocytes in a peripheral smear? It would be greater than what? The MCV. Greater than 94. So let's just try and tie up this megaloblastic anemia and say something about it. Remember that it results from an inhibition of DNA synthesis during red blood cell production. So when the DNA synthesis is impaired, the cell cycle cannot progress from the G2 growth cycle to the mitosis stage, and this leads to continuing cell growth without division, which presents as macrocytosis. So what are the causes of megaloblastic anemia? Firstly, vitamin B12 deficiency, which leads to folate deficiency. And remember about deficient intrinsic factor. The molecule is produced by cells in the stomach that is required for B12 absorption. So then we can think about pernicious anemia.